for the GGMC educational webinar series. I am Alex Gentry Maharaj from UCL, and it would be a real pleasure to welcome Dr. Vindya Subasinghe, who is a post-MD trainee specializing in clinical genetics from Sri Lanka. Since 2023, she has served as a clinical fellow in genetics at Birmingham Women's and Children's NHS Foundation Trust. After earning her MD in Pediatrics in 2020, Dr. Subasinghe deepened her expertise in rare diseases through hands-on experience in specialist genetics clinics across the West Midlands in England, and by actively participating in national and international genetics conferences. She is also dedicated to educating the next generation of clinicians, teaching both undergraduate and postgraduate students in clinical genetics. So today we'll hear from Dr. Subasinghe, who was inspired by the clinical and radiological approach to the diagnosis of skeletal dysplasia, the course which was conducted by the Skeletal Dysplasia Group. This talk highlights the importance of recognizing key radiological features in skeletal dysplasia, a vital skill in clinical genetics. And without further ado, I'll just briefly mention the talk will try and identify key radiological markers, practical insights to enhance diagnosis in clinical setting, and the value of learning through real patient cases to deepen our knowledge. So very welcome. And over to you, Dr. Subasinghe. Welcome to the webinar series.
Thank you very much, Alex, for that introduction. Hi, everyone. I would like to wish you good morning, good afternoon, and good evening for those who join from different time zones. So I'm really delightful to welcome you to the talk today. So today's aim is to explore often more complex and multifaceted area in medicine, that is skeletal dysplasia. So this is my outline of my talk. So we'll be talking about what is skeletal dysplasia, a bit about epidemiology and nosology, and how the patients can present to us, and how do we get a diagnostic approach to those who we suspect to have skeletal dysplasia. And then to take you through some real patient experiences that I had. So skeletal dysplasia is a heterogeneous group of heritable disorders which are characterized by abnormalities of cartilage and bone growth, and which results in abnormal shape and size of the skeleton and disproportionate growth of long bone, spine, and sometimes skull. Skeletal dysplasias are individually rare, but collectively they are common, accounting for incidence of 1 in 5,000 live births. And for the international nosology, there had been a revision last year, 2023. So with that revision, there's 771 conditions involving 552 genes. So as you can see on the slide, they have grouped the conditions based on the genes involved, based on the mechanism of pathophysiology, clinical features, and radiological features. It's quite complex with a significant number of conditions. So we'll see how we can make it easier in a way. So as they present, they have a wide and diverse spectrum of presentations. They can either present at different level. They could either be lethal, or they present very early, either prenatally or at birth, or some patients present during childhood, and some in the adulthood, and some there's a cohort that they don't present any symptoms. They're asymptomatic. So as we discussed before, they affect bones, cartilage, and connective tissues, again, a spectrum. And the genes responsible have a pleiotrophic gene effect on other genes as well. Therefore, they can have the involvement of other systems, so have extraskeletal features as well. Skeletal dysplasias per se gives rise to a significant burden of morbidity due to chronic pain, impaired mobility, and reduced quality of life, and sometimes due to reduced life expectancy. So how do these patients present to us? So if we consider prenatal presentations or at birth presentations, they can present with limb or chest deformity, bowing of the legs, pathological fractures, and sometimes congenital limb anomalies. Also, if you take an infant or a toddler, they can present as short stature or limb asymmetries or abnormal gait. Joint dislocations are also seem to be a presentation, and some people present with spine abnormalities, which is kyphoscoliosis or isolated scoliosis. They can also present with joint problems like mobility of the joint problems that can be either increased mobility or decreased mobility or joint pains. And rarely they can present with cranial nerve palsies as well. So let's see how we can approach a patient with skeletal dysplasia. So similar to the basic approach for any patient, history examination comes first. So in the history, since we know that these are heritable group of condition, it's really important that we go through the 3-generation family history, and very important to note consanguinity, because many of the conditions are inherited in a fashion called autosomal recessive way. And also in the history, it's important to note maternal histories of rheumatoid disorders and antenatal exposure to drugs, especially warfarin or sodium valproate, because as we now know that there are phenocopies for skeletal dysplasia, such as exposure to anti-rheumatoid factor antibodies antenatally, or exposure to warfarin, that is fetal warfarin syndrome and fetal valproate syndrome, gives rise to phenocopies of skeletal dysplasias. And then antenatal history is really important as for any other cases, or what sort of growth they had, any faltering, and if there is, in what stage of pregnancy. And obviously the key symptoms needs to be explored very carefully. And in the examination, it's really important, the growth parameters, especially the height, arm span, and if you suspect any disproportionate, we need to figure out that by getting the upper segment and calculate the upper segment to lower segment ratio. And when you examine the limbs, need to be very careful and thorough, noting what exact deformities they have. And as I mentioned before, they can have extraskeletal problems. It's really important to have a thorough examination head to toe as well. And then the spine examination is really important, together with the neurological examination, because we don't want to miss atelectaxial subluxation in some of the patients who present with skeletal dysplasias. So after history and examination, we probably able to categorize whether it is a skeletal dysplasia where there are multiple problems, or whether it's a limb anomaly just isolated. Depending on which we organize our investigation. So if it is skeletal dysplasia, we go for skeletal survey, which I will discuss in my next slide. And sometimes with the skeletal survey, we have a clear diagnosis, and then we can confirm it genetically. And similarly, when you have a limb anomaly, you don't need the skeletal survey, but only need specific X-rays, and you go for the diagnosis from your radiological features, then to confirm it genetically. Sometimes in both instances, we may not, even if we have the clinical information and radiological features, we might not be able to come to a diagnosis. Then it must be a really difficult case. And again, we then go for genetic testing. So in terms of genetic testing, depending on where you are and what facilities you have, it may be either doing a gene panel testing or skeletal dysplasia panel, whole exome sequencing or whole genome sequencing. So when we talk about the skeletal survey, it is really important when we do the skeletal survey. So it should necessarily be done before puberty. And some radiological features tend to tend to fade over time. So preferably it should be done before 4 years. So when we order the skeletal survey, we don't want to expose children for unnecessary x-rays. So we need to be really specific what we are doing, actually the views. So in the skull, we need the lateral view. In the spine, AP and lateral view, where we see T1 to L5 very clearly. And when we do chest x-rays, we need to see the shoulders, and in pelvis and hip, AP view. And if we have any limb abnormalities, if it is generalized, we just want one side. So we order leg x-rays, exposing the knee and then ankle, AP view. Similarly for the forearm. And when we do hand x-rays, we tend to order a PA view because it's more informative. And feet x-rays are very rarely needed unless you suspect a condition called chondrodysplasia punctata. You don't necessarily do feet x-rays because in chondrodysplasia punctata, you get epiphyseal stippling. The early stippling can be seen in ankle and distal phalanges. So as clinicians, we have to have somewhat general understanding of what we are dealing with in terms of x-rays, because we are seeing lots of patients with skeletal dysplasia. So we focus on looking at the specific anatomical sites, not to miss anything. So when we looking at the anatomical sites carefully, not to miss any fusions of the corpus and tarsal bone is important. And when we do the x-rays, we need to be mindful about the bone mineralization, unusual calcifications, and specific skeletal features. So in weird cases, we need to get help from our radiology colleagues. And when I say specific skeletal features, there are some pathognomonic features which will instantly give you the diagnosis. So in next 2 slides, I'm going to show a few x-rays to give you some insights of those pathognomonic features. There are many, but it's going to be few. So this is a child who presented with short stature. And when you examine, you know that she has relatively small hands. And when you do the x-rays, this is what you have. So there's very characteristic striking features that you see here. So that is the phalanges are different. So we call it angel-shaped distal phalanges. So this clearly give you the diagnosis of angel-shaped phalangoepiphyseal dysplasia. And then this is next is a hip x-ray. So there's no history. If you look at the x-ray, what are you seeing here? So if you see carefully, you will see that there's iliac horns. So iliac horns is very suggestive of a condition called nail patella syndrome. See, it is, if you suspect a patient to have nail patella syndrome, you need to actively look for it sometimes because this is a feature which is very easily overlooked. So depending on the radiological features, to make the diagnosis and differential diagnosis easy, the skeletal dysplasias can be classified into skeletal dysplasia families. So some conditions have very pathognomonic features. So the list is here. So if you have osteoporosis, bowing and fractures, you suspect osteogenesis imperfecta. And if it is punctate calcification, you classified in the punctate family of conditions. And when there is sclerosis, you tend to think of osteoporosis, osteopetrosis, sorry. And if there is undermodeling bowing, we tend to think of filament-related conditions. So if there are no phenylpathognomonic features, then we need to see whether there's any involvement of the spine or not. So if there's spinal involvement, plus there are other features, we categorize them as dysostosis multiplex, and then it is more towards a diagnosis of mucopolysaccharidosis or mucolipidosis. When there is a spinal involvement with interpedicular distance narrowing when you go down, with trident iliac bones, with proximal femoral scooping, then it comes under achondroplasia family of GFR3 family. When there is severe platyspondyly with overface pedicle, you tend to think of metatrophic dysplasias. If it is moderate platyspondyly, you tend to think of spondyloepiphyseal dysplasia congenita family. And there's two others when there's spinal involvement, depending on whether you have joint contractures or joint dislocations. So when there's joint contractures, you tend to think of dystrophic dysplasia family. And when there is joint dislocations, again, a filament-related condition, so Larsen family. When there is no spinal involvement, then we look at the other features. So there's three categories. One is when there is short ribs, it's very characteristic of skeletal ciliopathies. And when there is epiphyseal involvement, it categorized under multiple epiphyseal dysplasia, as the name implies. And when there is metaphyseal irregularities, you tend to think of skeletal ribosomopathy family. So this is some insight about the skeletal dysplasia families. And then I would like to go through some real patients to get more flavor of it. So this is the first patient, who is a 10-year-old boy who presents to us. So he is born to consanguineous parents. Antenatally, they were concerned about short limbs and talipes. He was born with normal vaginal delivery at term with healthy birth weight, and the skeletal problems detected at birth were bilateral severe talipes equinovarus deformity, bilateral flexion deformities of the hip, bilateral patellofemur subluxation. And when we saw him, he had short stature with spinal abnormality, which is a thoracolumbar gibbous deformity, but otherwise he was normal with normal intelligence. So this was the X-ray. So you can see here that he has marked irregularities in the vertebral end plates with loss of height at every level, suggesting of a severe spinal dysplastic process. And when you see the X-ray lateral, you see the bullet-shaped vertebrae as well. So in the hip X-ray, there was hyperplastic femoral epiphysis, as you see from the arrows. Again, the epiphysis hyperplasia was noted in the rest of the parts of the body as well. So with the history of dislocation and the spinal involvement, it comes, we tend to think of a category of Larsen's family. So we did whole genome sequencing, which picked up a variant, homozygous sequence variant in CHST3 gene, which confirmed the diagnosis for him as autosomal recessive spondyloepiphyseal dysplasia with joint dislocations. So, as I mentioned before, there are extraskeletal features as well. So, in this particular condition, it is known to associated with structural heart malformations and valve problems. So, we referred him to cardiology. So, that is the importance that we arrange necessary surveillance. Most of those conditions are not treatable, though we can prevent life limiting or sometimes debilitating complications by the diagnosis. So moving on to the second case, this is a baby who was presented at birth. So this was the first pregnancy for the non-consanguineous couple, and antenatally there was a concern at 20-week scan that the baby is having skeletal dysplasia, which is thought to be lethal. And they've counseled the couple and planned comfort care at birth. However, the baby was born at term with normal vaginal delivery. Surprisingly, the baby was in relatively good condition, except for mild respiratory distress. He was fine. But noted to have small thorax and relatively small humeri and femur. And the growth parameters at birth was weight on the 9th centile, length 25th centile, head 50th centile, and there was rhizomelic shortening of the limbs and narrow chest. Hands and feet examination was normal. So this was the X-ray. So you see a very narrow chest with short ribs here with some anterior, slightly bulbous anterior ribs. The clavicles look normal and the spine as well. So normal spine, no spine involvement with short ribs, we tend to think of skeletal ciliopathies. So when we do a trio WGS, we found that the boy is compound heterozygous for variants in DYNH2H1 genes. Both of the variants were pathogenic, and we confirmed the inheritance as well. So it confirmed the diagnosis of DYNC2H1 related short rib thoracic dysplasia 3 with or without polydactyly. So, ciliopathies, as we all know, have multi-system involvement. So, depending on the extraskeletal manifestation that this condition can have, we referred the child to relevant specialties, considering the eye abnormalities that they can have and the cystic lesions in the liver, pancreas, and kidneys. So moving on to the third case, so this is an 8-year-old girl who presented with progressive bowing of the left tibia, and there's a family history of suspected multiple epiphyseal dysplasia in mom and maternal uncle. There was nothing in the antenatal period, and the girl was born by C-section because of maternal skeletal problem, and also she was noted to have some learning difficulties. So the examination revealed that she had bowing of the left tibia and lumbar lordosis. Her height lied on the 9th to 25th centile, same for the head circumference, and the weight on the 25th centile. So this was her X-ray of the leg. You will appreciate that there is wide metaphysis of the knees with small epiphysis. So it was thought that the metaphyseal changes are secondary to epiphyseal changes. Apart from the skeletal problems, she was complaining of severe back pain, so they have done spinal MRI, which is not something we routinely do for skeletal dysplasias. But since we have that and it showed some changes, I have put up the picture of the spinal MRI spine here to show the end plate irregularities in the vertebral column. And so the spinal cord looks normal though. So there is spinal involvement with epiphyseal changes. So it comes under spondyloepiphyseal dysplasia category. When we do genetic testing, it picked up a heterozygous likely pathogenic variant in USFP2 gene, which confirms a diagnosis of epimetaphyseal dysplasia or dysplasia. And we offered cascade testing for the family members who were affected, which confirmed their diagnosis as well. And this gene is relatively a new gene, which was described in 2018 to be associated with spondyloepimetaphyseal dysplasia. So there had been very limited information. So following a literature review regarding the patients reported, we could able to give information to the family as to what they could expect with this diagnosis. Moving on to the fourth case. So this is a boy who presented to us at the age of 7 years. He was the third child born to healthy consanguineous parents. And in the antenatal period, there had been concern about fetal growth restriction. And he was born with relatively low birth weight of 2.1 kilos. And at birth, he was noted to have large head and short arms with hands. And he was born elsewhere outside UK and had suggested to have a diagnosis of achondroplasia. So the parents moved to the UK with the hope of having treatment for achondroplasia. He was intellectually normal without any medical problems. So when we saw him, his height was on the minus 6.4 SD, OFC on minus 2.7 SD, and there was frontal bossing and slightly narrow chest. So what was striking was he had limb shortening, but it was mesomelic shortening and with broad and short hands and feet. And his back examination was normal. He didn't have any dysmorphic features. And to examine the other family members, parents and siblings, they were all were at average height. So this was very striking with, and it was very difficult because the family had the thought that he has achondroplasia because of the mesomelic shortening. It's unlikely to be achondroplasia. I hope you all will agree with that. So it could be an alternative diagnosis. So we went ahead to do the skeletal survey and discuss it the multidisciplinary meetings. So these are the X-rays of the skull. It was all normal, and same for the chest. And when you look at the X-rays of the limb, there is in the upper limbs, you will appreciate that there's short, long bones which are mesomelic with a little bit of bowing as well. And when you look at the X-rays of the hand, there's short metacarpals and short bowed phalanges. Also, it is striking that he has a notch on the fifth metacarpal bone, which gives somewhat clue to acromesomelic dysplasias. And in the spine, he had platyspondyly, and pelvic X-ray showed narrow-looking femoral necks. So when we do a whole genome sequencing, applying the skeletal dysplasia panel, we found out a homozygous likely pathogenic variant in NPR2 gene, which confirms the diagnosis of autosomal recessive acromesomelic dysplasia type 1. So this was actually a very big turning point where the parent had got very big information because they were expecting a treatment for him, but this particular condition is not having treatment to date, and they tend to be really short as adults as well. So we need to counsel the family and arrange the necessary management depending on the symptoms involving other teams, because it is known that they can get some people with acromesomelic dysplasia can get some spinal problems as well. So moving on to the last case. So this comes up at the fetal pathology MDTs. So it was a termination of pregnancy at 23 weeks for fetal abnormalities, which was thought to be lethal bone developmental abnormalities. So this was the second pregnancy, and the couple had one previous term delivery, and that child was healthy. And in the postmortem examination, it revealed that the fetus had short limbs, and the x-rays showed reduced bone density, multiple fractures of old bones, and irregular long bones. So it was thought that this is a form of lethal osteogenesis imperfecta. So we discussed this in the fetal pathology MDT regional meetings that we discussed fetal pathology cases with the involvement of perinatal pathologists, clinical geneticists, fetal medicine specialists, and clinical scientists. So it was decided that we offer osteogenesis imperfecta gene panel for this fetus to find a variant which is likely pathogenic in the COL1A1 gene, which confirms the diagnosis of osteogenesis imperfecta. So it's most likely to be de novo, as we know commonly, but osteogenesis imperfecta is a difficult one to counsel because it can have two different things commonly. One is somatic mosaicism, and the other one is germline mosaicism. So the somatic mosaicism is up to 16%. So although the parents are healthy and there's no family history even of minor fractures or anything similar, we offered parental testing for targeting the variant identified in the affected fetus. Luckily, both parents were negative, but we can't rule out the germline mosaicism. We counsel them, given the recurrence risk of 5 to 7%. So that's all the cases that I have to present. So in summary, advances in genetic testing is a turning point in the diagnostic utility of not only skeletal dysplasia, all the rare diseases, helping families with adequate information regarding inheritance and recurrence risk. And detailed phenotypic evaluation is complementary work in the modern practice, owing to the number of variants of uncertain significance that we found in human genome. When we analyze sequencing data, the phenotypic information is extremely important. So I believe that learning from patients really deepen our understanding and also enables us to diagnose patients effectively with the experience that I shared. So that brings to the end of my presentation. I would like to thank Dr. Esther Kinning, consultant clinical geneticist, with whom I worked very closely with bone clinics. And also would like to mention about the two insightful courses that I followed recently. One organized by Skeletal Dysplasia Group UK, which was a 3-day course, which was really helpful. That was in May, and the recent one I attended, Dysmorphology and Syndromology course organized by European Society of Human Genetics. That's again a really good ones. So thank you for listening, and I'm happy to take any questions.
Thank you so much, Vindya, giving us a very comprehensive view of skeletal dysplasias. Is rare, or as you say, perhaps not so rare disorders, and going through the case reports or the case studies. I'm going to open the floor for questions. If anybody has anything that they would like to ask.
I'm very new to this group, so
yes.
Can you hear me well?
Yes, we can hear you.
Just,
please go ahead.
I don't know, Vindya, I don't know where you're working out of, and are these exomic genomic analysis, is it paid by the public health system, or is this through research collaborations?
No, actually, this
I
is
missed
the
introduction,
patients
so
that
I
I've
don't
seen in
even know.
NH.
Okay, sorry.
Okay, so I'm been one of the clinical fellows in Birmingham Women's and Children's NHS Trust. So in the UK, we do have whole genome sequencing funded by NHS. So that was a luxury, actually, I would say, for patients as well as for us as clinicians, because we can they're readily available, although the turnaround time would be 9 to 12 months, but they have whole genome sequencing.
Thank you.
Don't know whether anybody else has any other questions. Maybe I can ask you one or two. So I guess now what you present, we have a lot of data, or at least some pathogenic variants for some of the skeletal dysplasias, to, I guess, help the diagnosis and put into, I guess, the context of the dysplasia and future risks, whether they're cardiac risks or otherwise, so that there's an optimal, I guess, multidisciplinary care. But if we think with, I guess, the genetics hat and what we are able to do, can you see using these pathogenic variants for screening in utero, or trying to find gene therapy or anything along those lines? This is not my area, so I don't know what the advancement and what, I guess, the clinical and scientific community is thinking about now that we have this knowledge, which I presume we didn't have, let's say, 10, 20 odd years ago.
Yeah, so thank you for that question. Actually, yes, by confirming the genetic diagnosis, there are two sides to it. So we can have the diagnosis confirmed and offer the necessary surveillance, as you mentioned, and also there are certain conditions that they develop gene therapy on our treatment. So it's important that we have the genetic diagnosis for the patients, even if there are no treatment at the minute. But we do encourage patients to have the genetic testing, because sometimes, when we do consultations, people might think, yeah, no, if you don't think that there's a treatment, why do you want to do testing? But it's not the case. In the time that there are things moving on and there's new treatments coming up, so it's important that we have the genetic confirmation of things. And the other thing, when we talk about the recurrence risk, and that this may not be applied to every region, but here in the UK, what they do is they offer prenatal testing. So, for example, for the last case that I presented with osteogenesis imperfecta, which is having a recurrence risk of 5 to 7% at the end of all investigations, which is quite high, I would say, because most of the rare ones, with the de novo ones, we have the recurrence risk of less than 1%, but here it is 5 to 7%. So these couples are eligible for prenatal testing. So either they can, although the prenatal tests are invasive, at the same time, when we give the results, we consult about the prenatal testing, giving the recurrence risk of miscarriages, and offer them to contact in the next pregnancy. So we offer either chorionic villi sampling or amniocentesis. Then they can test for the familial variant that had been identified, and that's where they decide whether they want to continue the pregnancy or not. So in countries where the termination of pregnancy is legalized, that is one option that is possible. So in the UK, they practice that. So the couples can have their decision to do that if the pregnancy is affected.
Okay, thank you. I think Ronglin, you have a question?
Yes. Yeah, I have a question and also a comments. It's a wonderful presentation and very informative. My question is that you found that those genes, some are recessive disorder, some are autosomal disorder. Have you found the connection of those genes, and are they all in the same biological or pathological pathway?
Do you mean the testing? So what we do, although we use the technique of whole genome sequencing here, what they apply is skeletal dysplasia panel, which collectively obviously contains for more than 500 genes in it. So that's how that is applicable to everyone whom we suspect skeletal dysplasia.
Yes, and you found the different genes related to the same disease. Have you found the connection of those genes, and or have you found from the literature review or from other report, all those genes in the same biological pathway or pathological pathway?
No, they're different pathways.
Okay.
It's so yeah, they're different pathways actually. So the skeletal dysplasia families, so they are in different pathways. They're really complex, you know. There's more than 700 cases with involvement of more than 500 genes. So they're really complex.
Okay.
Yeah.
Interesting. Great. Thank you.
Okay.
Thank you, Rongling. So, Vindya, there's another question. Is PGD reimbursed in the UK?
Yeah,
I guess
yeah.
in
It's
other countries opening it.
Yeah, so the PGT is here the NHS funding for PGT is eligible for the couples who have no healthy children. So if they have a condition that is inheritable, having 50% or 25% recurrence risk, the couple is eligible for PGT. So that's one other option that we give for them. But in the cases where there are healthy children, even if they have one healthy child, they are not eligible for funding.
So they have to have a child with skeletal dysplasia in the family to be eligible for the PGD for the next pregnancy.
Yeah, so they have to have the genetic diagnosis has to be confirmed, and they need not to have they are eligible if they don't have any healthy children. So if you take an autosomal recessive condition, so we see in the couple of cases that have presented, so one child is affected and there's two children who are healthy, but they are not eligible for the PGT for the next pregnancy or pre-implantation genetic testing because they have two healthy children. If they have no healthy children, they are eligible. So even in the osteogenesis imperfecta case, because they have a healthy child, they are not eligible for PGT or pre-implantation genetic testing, but they are eligible for prenatal testing.
Okay. That's
Did I confuse you? Is it clear?
I think that's clear. So I guess I don't know whether anybody else has a question, but maybe I can ask one more, if I may. So you work with the Skeletal Dysplasia Group. So you work with patients, and if you ask them what do they need and what, according to them, are the unmet needs and the support, what are their reflections on how we can support them and what can be done? Because it's, you know, the PGD and PND, it's one aspect of it, but do they have any suggestions of how
in
they can
terms of
support with the children, especially if they have a child with skeletal dysplasia and one without, or what would be quite interesting to understand?
Yeah, well, Yeah, so in the UK there are lots of charities. So there's rare disease charities where they support these children with rare diseases. So there are some conditions that they have disease specific charities for achondroplasias, and some there's a charity called Small People UK charity. So they have, once we have the diagnosis, we usually tend to signpost them in their charities, so the children will get the support from them in terms of mobility or other social aspects and stuff. And in terms of the parents, for the next pregnancies, talking about the pre-implantation testing and the support in the next pregnancies, what is available here in the UK is we have, in genetic point of view, we have dedicated prenatal team who deal with the pregnancy, the next pregnancy. So once the couple get the next pregnancy, what we usually ask them to contact the genetics very early in the pregnancy, so they can have discussions as to what we can do in the next pregnancy. Because what we usually find when we do the when we have the diagnosis and give all the bad news information to the families, they're sometimes not thinking of another pregnancy, or they don't have any clue whether they're going ahead or not. But with time, they will change their mind, and that's really helpful. But what we usually give them are contacts about the prenatal team to contact us in any case. So there's open access for that for them. So no need to go through the GP pathway or anything like that. They can directly contact genetics to get their support as early as possible, because when we talk about the prenatal diagnosis, it's really important we deal them really quickly in case they wanted to terminate a pregnancy. Yeah, that's it.
Great. Well, thank you so much. Unless anybody has any other questions, we hopefully can wrap up this session. Thank you very much for delivering the webinar and giving us, I guess, the advances and still challenges in skeletal dysplasia. So very much would like to thank you for the time that you had given to us today, and also apologies to everybody that we had an IT glitch or Zoom link glitch, but hopefully we'll iron that out for the next webinar, which is in December, and we'll have Dr. Rich Haspel from Harvard Medical School talking to us. So thank you so much for attending today, and we'll see you next time.
Great. Thank you so much. Bye.
Bye. Thank you for inviting.
Thank you so much.